If you're here, you're looking for that essential, crystal clear knowledge buried inside some of the world's most complex medical topics. And today, we're taking on diabetes mellitus. It's a condition that affects hundreds of millions of people globally.
It really is.
And we are going to peel back the curtain on the incredible and often, really ingenious pharmacology that allows us to manage it. We're talking insulin, of course, but also the revolutionary new oral agents that are rewriting the rules of blood sugar control.
Yeah, the landscape has changed so much.
We've got a pretty dense stack of sources today focused very deeply on clinical pharmacology. So that means the chemical structures, the physiological mechanisms, and of course the crucial clinical trials that dictate treatment strategies.
Right.
Our mission is simple: to be your expert guide, unpacking this intricate dance between insulin production, insulin resistance, and the multi-drug strategies that keep patients stable. The goal is that you walk away understanding not just what these meds are, but precisely how they work.
Down to the molecular switches.
Exactly, down to the switches.
And I think we have to start with a precise definition because this gets oversimplified all the time.
Okay.
Diabetes mellitus is defined by persistent hyperglycemia. That means a fasting plasma glucose at or above 126 milligrams per deciliter, or over 202 hours after an oral glucose test.
But it's not just about sugar, right?
Not at all. It's a systemic metabolic disorder. And that means you see glycosuria, sugar in the urine, hyperlipidemia, and critically, a catabolic state, a negative nitrogen balance.
And in the worst cases.
In severe, untreated cases, this leads to ketonemia.
And here's the crucial nugget I think we need to hook you with from the start: that prolonged exposure to high glucose is what causes the really devastating long-term damage. Our sources highlight that this constant elevation promotes what's called enhanced non-enzymatic glycosylation of tissue proteins. I mean, basically, the sugar just permanently sticks to proteins where it shouldn't.
Exactly. We sometimes call them sticky proteins. And this process is so central to the whole pathology that we use a measure of it, HbA1c or glycosylated hemoglobin, as the gold standard index.
Right, that tells you the average over a few months.
It gives you a clear picture of the patient's average glycemia over the last 2 to 3 months. And these glycosylated proteins, combined with an accumulation of something called sorbitol, which is a reduced product of glucose, they are the molecular foundation for the worst vascular complications.
So the damage isn't the glucose just passing through the blood?
No.
It's the damage from it staying too long and permanently messing with the structure of blood vessel walls and nerves.
You've got it.
And that's how you end up with that trifecta of microvascular damage: retinopathy in the eyes, nephropathy in the kidneys, and neuropathy nerve damage.
Not to mention accelerated early atherosclerosis.
Right. Understanding that connection is absolutely key to appreciating why tight control is so vital.
It's everything.
So before we get into the arsenal of drugs, we have to establish the fundamental distinction that drives all the treatment decisions.
Yep.
Type 1 versus type 2.
Yeah.
They share the symptom, hyperglycemia, but the cause is completely different. And so is the strategy.
Completely different. Type 1 DM, which we used to call insulin-dependent or juvenile onset, is fundamentally an issue of supply.
Okay, supply.
It's characterized by the physical, often catastrophic destruction of the insulin-producing beta cells in the pancreatic islets.
And the majority of these cases, type 1A, are autoimmune.
That's right.
The patient's own immune system is making antibodies that just destroy their own beta cells, which means there's an absolute lack of insulin. It's not a malfunction, it's a complete factory shutdown.
A factory shutdown is the perfect way to describe it. And the consequence of that absolute lack is a strong propensity for ketosis.
Right, because there's no insulin to stop fat breakdown.
Exactly. Lipolysis runs rampant, generating those excessive ketone bodies we talked about, and that leads to diabetic ketoacidosis, or DKA. That's the hallmark clinical feature.
And it's interesting, our sources note that type 1 has a pretty low degree of genetic predisposition compared to type 2. It's more of an autoimmune event.
It is, triggered by environmental factors in people who are genetically susceptible.
Okay, so that's type 1. In stark contrast, type 2, or maturity onset, it's more an issue of usage or response.
Yes. In this case, the beta cell mass might only be moderately reduced, or it might be fine. Insulin levels can be low, but often, especially early on, they're normal or even high. The body is trying to compensate.
Because the core problem is insulin resistance.
That's the pathogenic core of type 2. Significant insulin resistance in the peripheral tissues, liver, skeletal muscle, fat. The tissues just aren't responding properly to the insulin that is there.
So type 1 is a door with no key. Type 2 is a door where the lock is rusted shut, even if you have hundreds of keys.
That's a fantastic analogy, and that's why the treatment approach for type 2 focuses so heavily on, well, lubricating that lock, on overcoming the resistance. It's why most of our oral medications are designed specifically for type 2.
Right. Which, from a public health perspective, makes sense because type 2 is the dominant form globally, and it's so tightly linked to lifestyle.
Profoundly linked to obesity and physical inactivity.
So let's pivot to the key itself.
Yeah.
Insulin. I mean, it is the cornerstone. And the story of its discovery and its chemistry it's just incredible.
It's one of medicine's greatest narratives. Before 1921, before Banting and Best, a type 1 diagnosis was a death sentence.
Often within months.
Yeah. And the brilliance of their early experiments was solving a very practical problem. How do you isolate this hormone without it being destroyed by the body's own digestive enzymes from the pancreas?
And the genius was in this technique. Pancreatic duct ligation. They tied off the duct.
Right. Which caused the exocrine tissue, the part making the digestive enzymes, to just degenerate, but it left the islets of Langerhans, the endocrine tissue, intact.
So they got rid of the digestive juices.
Exactly. And by doing that, they could create a crude extract that, when they injected it into diabetic dogs, dramatically lowered their blood sugar. It was the proof.
And the stories of them using it on dying children are. They're just miraculous.
It was. The extract was purified into a crystalline form just 5 years later, but it took until 1956 for Frederick Sanger to fully map out its complex chemical structure.
Which is pretty complex for a hormone. It's a 51 amino acid, 2-chain polypeptide.
Yeah, an A chain and a B chain, held together by 2 disulfide bonds. And that structure dictates everything.
And it's fascinating to look at the species homology, which was so important in the early days.
It was everything. Before recombinant tech, we got insulin from cattle and pigs. And we know now that pork insulin is much more similar to human insulin. It only differs by 1 single amino acid.
Whereas beef insulin differs in 2 positions.
Right. And that tiny structural change can increase the antigenicity, the chance the body sees it as foreign and attacks it.
Which is why purified pork insulin was the gold standard for so long. Fewer allergic reactions.
Until we could finally clone the precise human sequence in the 80s.
So let's talk about how the body actually makes it, the synthesis.
It's a multi-stage process. It starts as a big molecule, pre-proinsulin, gets cleaved down to proinsulin.
And then the key event happens. This connecting part, the C-peptide, is split off.
Yes, a 35 amino acid strand is removed, leaving the active 2-chain insulin molecule. And the insulin and the C-peptide are then packaged together and secreted side by side.
And this brings up a really important clinical clue, right? The C-peptide. Why do we care about what seems like a waste product?
Because measuring C-peptide in the blood gives you an invaluable, unambiguous insight into how much insulin the patient's own pancreas is producing.
Right, because if they're taking injections, you can't tell what's theirs and what's the drug.
Exactly. But the C-peptide is only made during the synthesis of their natural insulin, so its level is a reliable marker of the remaining beta cell function. It's a crucial diagnostic tool.
Okay, so the regulation of insulin release. It's a masterpiece of metabolic fine-tuning.
It really is. The pancreas secretes about 1 unit an hour just for basal needs, but after a meal, that output just skyrockets.
And it's responding to a triad of signals, chemical, hormonal, and neural.
The main regulator is chemical, glucose itself. The beta cell is a perfect glucose sensor. Glucose comes in via the GLUT1 transporter. It gets metabolized, and this generates ATP.
And that's the molecular switch.
That's the switch. The rise in ATP specifically inhibits the ATP-sensitive potassium channel.
So it closes the potassium gate.
Right. And blocking that potassium from leaving causes a partial depolarization of the cell membrane. That depolarization then opens voltage-sensitive calcium channels, calcium floods in, and that's the final signal for the release of the stored insulin granules.
And it's timed perfectly. There's a quick pulse, the first phase.
Within 2 minutes. Crucial for handling that initial glucose spike. And that's followed by a more delayed, sustained second phase of release to maintain control.
And we have to talk about the incretin effect, because this is amazing. Glucose given orally is 2 to 4 times more effective at releasing insulin than glucose given intravenously.
Yeah, why is that?
The gut is talking to the pancreas.
Exactly. As food passes through the GI tract, cells release incretins, mainly GLP-1 and GIP. These are anticipatory signals. They boost insulin release before the glucose has even fully hit the bloodstream. It's proactive control.
And that system is so powerful, it's become a target for A whole new class of drugs we'll get to
A
later.
huge class.
And then there are the interactions inside the islets themselves. It's like a tiny regulated neighborhood.
A perfect description. The beta cells making insulin talk to the alpha cells making glucagon and the delta cells making somatostatin.
So insulin inhibits glucagon.
Right. You don't want to be mobilizing fuel while you're trying to store it.
And somatostatin is like the watchdog.
Yes, it inhibits both insulin and glucagon, preventing any metabolic overshoots. And conversely, glucagon actually stimulates the release of insulin and somatostatin. It's this constant feedback loop for fine-tuning.
Generally the brain gets involved. Neuromodulation.
Vagal stimulation, part of the rest and digest system, increases insulin secretion. But the sympathetic fight or flight response is more complex. It mostly decreases it.
Which makes sense. During an emergency, you want to keep fuel, glucose circulating for your muscles and brain.
So you temporarily suppress insulin release. It all fits together.
So let's talk about what insulin actually does once it's released. Its overall mandate is simple: store fuel.
Exactly. It's the major anabolic hormone. It promotes the synthesis of glycogen, lipids, and protein.
And it all starts with getting glucose into the cells. Insulin facilitates glucose transport into the really sensitive tissues, skeletal muscle, and fat. It does that by regulating the GLUT4 transporter.
And here's a crucial distinction for everyone listening: the limitless versus limited transport rule.
Okay.
Glucose entry into muscle and fat is limited by insulin. Without insulin, the doors are locked. But glucose entry into organs like the liver, the brain, red blood cells, that's largely independent of insulin.
That is so important. It means the brain can still get the glucose it needs to function, even in a type 1 diabetic with zero circulating insulin.
Exactly. But once the glucose is inside the cell, insulin's job continues. It enhances phosphorylation, it stimulates glycogen synthesis, and it shuts down glycogen breakdown. It's incredibly efficient.
And so much of insulin's job is defined by what it prevents: the catabolism.
Yes. It suppresses hepatic gluconeogenesis. It stops the liver from making new glucose from scratch.
So when insulin is gone, like in type 1, the whole system just flips on its head. Catabolism takes over.
It does. Proteins get broken down, releasing amino acids that the liver then turns into more glucose and urea. That leads directly to a negative nitrogen balance. The body is consuming itself for fuel.
Which brings us right back to that dangerous link between fat metabolism and ketosis.
Right. Insulin's job is to inhibit lipolysis, fat breakdown. So in the diabetic state, hormones that promote fat breakdown like glucagon and adrenaline are completely unchecked.
And the blood gets flooded with free fatty acids.
The liver tries to process them, but the pathways to resynthesize them into safe triglycerides are impaired. So instead, all that acetyl-CoA gets diverted to produce massive amounts of ketone bodies.
And when production outpaces the body's ability to use them,
You get DKA, acidosis, metabolic emergency. It all stems from that one initial trigger: a lack of insulin.
so how does it actually work at the cellular level, the mechanism?
It acts on a specific receptor, tyrosine kinase, or RTK. It's a huge glycoprotein, and they're particularly dense on liver and fat cells.
And the receptor has two parts, right? The outside part that binds the insulin and the inside part that has the enzymatic power.
Correct. Insulin binding activates the kinase activity of the inner beta subunits, and that starts this massive internal cascade of phosphorylation reactions.
Signal amplification.
Yes, the initial signal gets relayed inward through docking proteins. A key player here is PI3 kinase. Think of it as the general manager who gets the urgent message that glucose is outside and needs to come in.
And the critical order that manager gives is the translocation of the GLUT4 transporters.
Exactly. These transporters are just sitting in vesicles inside the cell. The signal tells these vesicles to fuse with the cell membrane, which instantly creates new doorways for glucose to enter. That's the rapid action that handles a post-meal glucose spike.
So we've seen how elegant the natural hormone is. Now let's get into the pharmacological challenge.
Yeah,
How do you take this protein and make its timing match what a person actually needs?
that's the whole game.
We talked about the early beef and pork insulins. They were crude, they had contaminants, and they caused immune reactions over time.
Yeah, and the 1970s brought that purity revolution with monocomponent, or MC insulins. They cut the proinsulin contamination way down.
But since the 80s, it's been all about recombinant DNA-produced human insulin.
It's the standard now, and while our sources note its clinical superiority over highly purified pork insulin was never actually proven, the consistency of supply and, moving away from animal sources made it the only logical choice.
But the timing problem was still there. We need a fast spike for meals and a slow, steady release for basal coverage.
Right. And regular or soluble insulin, the unmodified form, its key mechanical issue is that the molecules self-aggregate into hexamers clusters of 6.
So it's like a convoy of 6 trucks trying to get down a single-lane road.
Perfect analogy. The hexamers have to slowly break apart before they can be absorbed, and that slow absorption is the flaw. The peak action is delayed by 2 to 3 hours.
Which creates that classic mismatch. Early post-meal hyperglycemia, followed by risky late hypoglycemia.
Which is why patients were always told to inject it an hour before eating. It was a workaround.
And the exception here proves the rule. Regular insulin is the only one you use for an IV injection.
Because once it's in the bloodstream, the high dilution makes the hexamer dissociate instantly. You get that rapid action you need in a crisis like DKA.
And for basal coverage, they developed intermediate-acting preps like NPH.
Right, NPH is complexed with protamine to slow it down. But while it lasts 12 to 20 hours, the absorption is just notoriously inconsistent. It leads to unpredictable sugar levels.
And that unpredictability led to the modern solution. Analogs. Chemists literally modifying the amino acid sequence to solve the timing problem.
This is where the true ingenuity is. Look at the rapid-acting analogs, Lispro and Aspart. For Lispro, they just reverse 2 amino acids. For Aspart, a single substitution.
And that tiny structural change completely changes the physics.
It drastically reduces the tendency for those hexamers to form, or if they do, they're super weak and break apart instantly.
So instead of a slow convoy, you have single motorbikes ready to go.
And the result is an onset of, 15, 20 minutes and a peak at 1 hour. It allows the patient to inject right before a meal, perfectly matching the action to the glucose load. It was a revolution in mealtime control.
Then you have the other side of the coin, the long-acting analogs, designed for that perfect basal trip.
Like insulin glargine. They made a couple of amino acid changes here, too.
And the mechanism is just a clever chemical hack.
It really is. Glargine is made to be soluble in the vial at an acidic pH of 4. But when you inject it into the neutral pH of your subcutaneous tissue, it immediately precipitates. It forms a microcrystalline depot.
So it creates its own little slow-release pellet under the skin.
Exactly. And that depot dissolves incredibly slowly, resulting in a relatively flat, peakless action that lasts a full 24 hours. This predictable, stable coverage dramatically lowers the risk of nighttime hypoglycemia compared to something like NPH.
But you absolutely cannot mix it with other insulins in the same syringe.
Never. The acidic pH would destabilize the other insulin.
And now, even beyond that, we have ultra-long-acting insulins like Degludec.
Which lasts around 40 hours, even flatter, even less variable. For the patient, that just means more flexibility and even less risk of that unpredictable nocturnal low.
So now that we know the tools, let's talk strategy. How do you put them together to mimic a healthy pancreas?
Well, the clinical goals are clear. Prevent the acute crises and delay those long-term vascular problems. We're aiming for specific targets: fasting glucose between 90 and 130, and an HbA1c under 7%.
The older way was the split mixed regimen. NPH and regular mixed together twice a day.
It was convenient, but it failed physiologically. The NPH was too inconsistent, and a single morning shot couldn't cover the post-lunch period properly.
So for the best, most complete control, the standard is the basal bolus regimen.
That's the intensive standard. You use a long-acting insulin like glargine once a day for stable basal coverage, and then you combine that with 2 or 3 mealtime injections or boluses of a rapid-acting analog like Lispro.
And that allows for dynamic adjustments. You can change your mealtime dose based on what you're actually eating.
Exactly. And the landmark DCCT trial proved that this kind of intensive therapy in type 1 patients markedly reduces and slows the progression of microvascular complications. Tighter control means less damage.
But there's always a but, a clinical reality.
There is. Intensive therapy, while great for long-term health, comes with a significantly higher risk of severe hypoglycemic episodes.
Which is why you have to be careful. You generally avoid it in very young children, where low blood sugar can harm the developing brain, or in the frail elderly, where a fall during a hypo event is a huge risk.
You always have to balance the risk against the reward.
Okay, circling back to type 2 and insulin resistance. It's defined as that suboptimal response to the tissues.
And it's heavily influenced by obesity, age, lack of exercise. Our sources suggest that for many, the problem isn't the number of receptors, but a faulty transducer mechanism. The internal wiring is just off.
Which is why exercise is so powerful, right?
Right.
It can activate glucose uptake through a completely different pathway, bypassing that faulty insulin signaling.
It has a profound insulin-sparing effect.
Yep.
Then you also have acute insulin resistance. This is short-term, caused by major physiological stress like an infection or surgery.
The body gets flooded with stress hormones that directly oppose insulin.
And that requires massive, immediate intervention with high doses of regular insulin until the underlying cause is fixed.
Okay, so when therapy fails, we face two very distinct emergencies. First, DKA, diabetic ketoacidosis, which is mostly in type 1.
DKA is a metabolic storm. Severe hyperglycemia, uncontrolled lipolysis leading to severe ketosis and acidosis. It causes massive dehydration and impaired consciousness.
And the treatment is urgent.
Very. Aggressive fluid replacement, an IV drip of regular insulin, and critically, potassium replacement.
Right, that potassium detail is key. The acidosis forces potassium out of the cells, so even if blood levels look normal, as soon as you start the insulin.
The insulin drives all that potassium back into the cells, causing a rapid, dangerous drop in serum potassium, which can trigger fatal arrhythmias. You have to anticipate it.
Okay, now contrast that with the other crisis, hyperosmolar coma, which you usually see in elderly type 2 patients.
This is characterized by much, much higher blood glucose, often over 600, and extreme serum osmolality.
But, and this is the key concept, ketosis is usually absent. Why is that?
Because the type 2 patient, even in crisis, usually has just enough of their own circulating insulin to suppress that massive runaway lipolysis.
So they have enough to stop the ketone production, but not nearly enough to control the glucose.
Exactly. The resulting hyperglycemia is so extreme it causes catastrophic dehydration, leading to that hyperosmolar state. Treatment is similar. Aggressive fluids are even more critical, but the insulin requirement is usually lower, and you don't typically need alkali because there's no severe acidosis.
And this need for precise dosing has driven innovation in delivery devices.
We have inhaled insulin, like Afrezza. It's a dry powder absorbed super fast from the lungs, acts in 10-15 minutes. It's designed to replace a mealtime injection.
It's convenient, it's fast, and they claim lower weight gain and hypoglycemia risk.
But it's not for everyone. It can cause a cough. You have to monitor lung function, so it's not for smokers or people with asthma.
Then you have insulin pumps, or CSII.
Continuous subcutaneous insulin infusion. It's a portable device that delivers a constant low basal rate of a rapid-acting analog, plus user-initiated boluses for meals.
So in theory, it's the closest you can get to a functioning pancreas.
In theory. But the data is a little disappointing. The source notes that no definite advantage of pumps over optimized multi-dose injections has been conclusively demonstrated in terms of strict HbA1c control. They're also expensive and require a lot of patient training.
Okay, let's move on to the management of type 2, where most of the action is with non-insulin agents.
Right, drugs that target the specific regulatory flaws in the system.
Starting with the injectables. The incretin system, GLP-1, is a huge pharmacological target now.
The GLP-1 receptor agonist exenatide, liraglutide, they mimic the action of GLP-1, and their mechanism provides a massive safety advantage.
Which is?
They induce insulin release, but critically, that release is glucose dependent. If your blood sugar is low, they are inactive, so they have a very low risk of causing hypoglycemia on their own.
They do more than that.
Oh yeah. They inhibit glucagon, they slow gastric emptying, and they suppress appetite.
So you get better glycemic control plus weight loss. It's a dual advantage.
A huge advantage. Liraglutide is even approved for obesity management on its own, and the newer ones only require a once-weekly injection.
But there are drawbacks. Nausea is common.
Especially at first. And we do have to mention the reported, though rare, risk of acute pancreatitis.
Then there's pramlintide, the amylin analog.
Amylin is co-secreted with insulin naturally. Pramlintide works by reducing glucagon, delaying gastric emptying, and promoting satiety. It's an adjunct to mealtime insulin to really flatten that post-meal spike in both type 1 and type 2.
Let's turn to the traditional oral agents that boost insulin secretion, the sulfonylureas, or SUs, the oldest class.
Right, they act directly on the beta cell. We talked about that ATP-sensitive potassium channel. SUs just bind to the receptor on that channel and force it shut.
So they're forcing an insulin release.
A forced release. And the flaw is baked into the mechanism. They provoke insulin release even when glucose levels are low. That glucose-independent action is what makes severe, unpredictable hypoglycemia their major, potentially lethal risk.
To address that, they developed the miglitinides, like repaglinide.
They also block the potassium channel, but they're very fast-acting and very short-lasting.
So you can use them more strategically.
Exactly. Patients take them right before a meal to target that specific post-meal spike. If you skip the meal, you skip the dose. It dramatically reduces the risk of that late hypoglycemia.
Okay, now for the heavy hitters. the drugs that actually tackle the core problem in type 2 insulin resistance. And we have to start with metformin.
The global first-choice drug for type 2.
Its key action is suppressing hepatic gluconeogenesis. It tells the liver to stop making so much unnecessary glucose.
That's its major action. And secondly, it enhances insulin-mediated glucose uptake in muscle and fat, helping the peripheral tissues overcome resistance.
And that leads to its major safety feature.
It's euglycemic. It doesn't cause hypoglycemia on its own because it doesn't force insulin release. It just makes the body more sensitive to the insulin that's already there.
I have to play devil's advocate here, though. The source mentions it activates AMPK, but that mechanism is still partly theoretical. The benefit of metformin on macrovascular events, like heart attacks, is huge. Are we sure it's the direct molecular action, or is it just the happy consequence of it promoting weight loss and avoiding hypoglycemia?
That's a really valid point. And while the exact molecular pathway is still being fully worked out, the clinical consensus is that all of its systemic effects act together. Whatever the precise mechanism, the clinical outcome from the UK PDS trial was clear. It reduced the risk of macrovascular complications and mortality. That's what cemented its status.
But we have to mention the risk, lactic acidosis. It's rare, but it's why it's contraindicated in people with renal insufficiency or heart failure.
Absolutely. The other core resistance fighter is the TZD class, the glitazones, like pioglitazone.
This one works by activating PPAR gamma receptors, mostly in fat cells.
Right. And by doing that, it fundamentally alters gene transcription. It enhances the cell's response to insulin, improves GLUT4 expression. It's a very effective anti-resistance agent.
And it has a nice effect on lipids, too. Lowers triglycerides, raises HDL.
It does. But this class is burdened by some really significant drawbacks. The most concerning is fluid retention,
which leads to edema, weight gain, and an increased risk of congestive heart failure.
which is why it's strictly contraindicated in patients with CHF. It's a powerful tool, but one you have to use with extreme caution.
Okay, the last two classes really show how modern pharmacology can target these incredibly specific steps.
They do. First, the DPP-4 inhibitors, or gliptins. These are oral drugs that inhibit the enzyme, DPP-4, which is responsible for breaking down your body's own natural GLP-1.
So you're inhibiting the inhibitor.
Exactly. You're prolonging the life of your body's own natural incretins. And the beauty is, you're using the body's existing safety mechanism. The resulting insulin release is glucose dependent, so low risk of hypoglycemia. They're weight neutral, good for beta cell health. They're excellent add-on drugs.
And then the newest, and maybe most striking class, the SGLT2 inhibitors.
These drugs target the sodium glucose cotransport 2 in the kidney, which normally reabsorbs almost all the glucose that gets filtered.
So by inhibiting that transporter, you're just forcing glucose to be excreted in the urine, a controlled glycosuria.
You are literally peeing out calories, which means they lower blood glucose and promote weight loss, and the mechanism is completely independent of insulin, which is a huge advantage.
But the mechanism also has its own inherent concerns.
It does. Excreting sugar in the urine increases the risk of urinary and genital infections, and they're contraindicated in renal insufficiency.
And finally, the simplest but often least popular agents, the alpha-glucosidase inhibitors like acarbose.
They just inhibit the enzymes that digest carbohydrates in the small intestine. They flatten the post-meal spike by slowing down sugar absorption.
But patient acceptability is notoriously poor.
It is.
Yeah.
Because the unabsorbed carbs get fermented by bacteria in the lower gut, causing predictable and socially challenging GI side effects. Flatulence, discomfort. It's a mechanism that works, but the lifestyle cost is high for many.
So we have this incredible, sophisticated toolbox. The crucial final step is understanding the strategy. How do clinicians use the lessons from these massive trials to decide which tool to use and when?
Well, the huge one was the UK Prospective Diabetes Study, the UK PDS. It followed thousands of patients for decades.
And it was seminal. It definitively found that SEUs and metformin did not increase cardiovascular mortality.
Right. But the real revelation was the metformin advantage. In the overweight group of type 2 patients, metformin not only reduced microvascular complications, it also reduced macrovascular events, heart attacks, strokes, and all-cause mortality.
And that finding is what elevated metformin to its current status as the mandatory first-line drug, pretty much everywhere.
It offered a unique protective benefit beyond just lowering glucose.
So based on that data, the hierarchy for type 2 is clear. First line is lifestyle management plus metformin, right at diagnosis.
Immediately. It's favored for its safety, its unique mechanism, and that cardiovascular protection.
And if metformin alone isn't enough,
You add a second drug. SUs are still the most common choice because they're effective and low cost despite the risks. But the choice can be tailored.
Right. A DPP-4 inhibitor is great for a patient who's prone to hypos or needs to avoid weight gain. Pioglitazone is for when resistance is the overwhelming problem, but only if they have no heart failure risk.
And it's important to remember type 2 is a progressive disease. Up to half of patients will eventually need to start insulin.
But when insulin is introduced, you often keep the oral agents going, especially metformin.
You do, because the basal insulin handles the background needs while the metformin keeps suppressing the liver's glucose output. This combination minimizes the total insulin dose you need and often helps with weight control.
And the injectable GLP-1 agonists are a strong alternative to insulin, especially in obese patients who really need to avoid the weight gain that often comes with insulin therapy.
Exactly.
So we focus on lowering blood sugar, but we have to acknowledge the flip side, the emergency backup for hypoglycemia, glucagon.
Glucagon is the counter-regulatory hormone. It's the hormone of fuel mobilization. It works opposite to insulin, rapidly enhancing glycogen breakdown and new glucose production in the liver.
So clinically, it's the emergency measure for a severe hypo when the patient is unconscious and can't take oral glucose.
A small dose can rapidly raise their blood glucose, but they must be followed immediately by oral glucose once they recover, and raises an important point. If the patient's liver glycogen stores are already depleted, glucagon just won't work.
Wow. We have navigated the elegant chemistry and the aggressive strategy of diabetes management today. We've pulled out the core knowledge, that distinction between the supply problem of type 1 and the resistance problem of type 2, the ingenuity of the rapid and peakless insulin analogs that solved a century-old timing problem,
Right.
and that critical safety difference between the old drugs like sulfonylureas with their nonspecific release and the new ones like GLP-1 agonists with their glucose-dependent safety.
And critically, we reinforced metformin's singular status as the first-line drug, favored not just for lowering glucose, but for its unique ability to tackle insulin resistance and provide that hard-won cardiovascular protection, a lesson cemented by the UK PDS.
So what does this all mean for you? You've seen that managing diabetes is this delicate, precise, pharmacological tightrope walk. You're constantly balancing the risks of high blood sugar against low blood sugar.
It's always a balance.
But the power we now have to manipulate these specific metabolic pathways, from a potassium channel in the pancreas to a glucose transporter in the kidney, it's just astonishing.
It is. And this leads us to our final provocative thought. The diabetes prevention program showed that both metformin and the glitazones have a powerful potential to delay or even prevent the progression from prediabetes to overt type 2 diabetes.
Right.
So given that type 2 is reaching epidemic levels globally, the question becomes, should we move beyond just treating symptoms and aggressively pivot towards proactive, preventative pharmacological intervention for the highest risk individuals, even before they get a full diagnosis?
And what would the logistical, ethical, and public health implications of expanding that pharmacological net really be for healthcare systems worldwide?
It's a huge question.
It is a fascinating question for the future of medicine. That's all the time we have for this deep dive. Thank you for joining us.